for remembering to record. Appreciate it. So everyone just note that we are being recorded. Hi, everyone. It's really good to see all of your faces. Thank you for making it today. And thank you for bearing with some of the technical challenges we had real early on. It's good to see all of you. I'm just going to say a few quick words and then we're going to dive into our discussion. In your room, we're going to be talking first about the close the gap model. And then as I said before, new facilitators are going to cycle in and you're going to talk about the two universal healthcare models subsequently. So each breakout group is going to get to discuss all three models. Right now we're going to focus on close the gap. As you learned from reviewing the videos in advance, the real variables here with all three of the models we're discussing, it's going to drive the analyses are who is covered and what are those benefits. And so that's what a lot of our questions are going to be about today. All of the questions that I'm going to ask you in this discussion are going to relate specifically to the close the gaps model. In some of the other discussions you're going to join, you may be getting asked questions that relate to both of the universal healthcare models. My role as facilitator, as always, is to try to get your feedback from all of you. So if I'm detecting that our discussion's veering off course, I might steer us back since we only have 29 minutes together for this discussion. And to make sure that we have actionable information coming out of this conversation, I'm going to ask you to be as specific as possible with your feedback. So for example, cap premium contributions at 5% of income is going to be more helpful than have affordable premiums. That's just an example. So just a quick reminder, you just heard the presentation, so I'm not going to go through in depth on what the fill the gaps model is, other than that it's the idea is it really models closely the cascade care model that has just gone into implementation, where individuals who lack access to affordable insurance covered options and have incomes below a certain level can access enhanced subsidies for certain exchange plans and obtain coverage with lower premiums and lower cost sharing. So, Liz, do you have anything you want to add to that before we get started?
That's it.
Okay, I also want to introduce you to Chris Dickerson from Optimus. He is our actuary who's going to be sitting in with us and answering questions or providing you with any insight from his perspective.
And I'm going to make, hi, I'm going to make a request. Jane, hi, I see your drive. You're in the car. Michelle was supposed to be in this work group with us to help fill in any information about Cascade Care. So I'm going to ask, I know you're up to date on the latest. So if there's anything relevant to our conversation related to that, can you please speak up?
Thank you. All right. Thanks, everyone. So let's get started. I'm going to ask a broader question than you might be asked in some of the other discussion groups, which is, what is your initial feedback on the Close the Gaps model? What's your initial reaction to it? And please raise your hand if you'd like to offer a reaction. Okay, I see Dr. Weinberg raising her actual hand. So Dr. Weinberg, I'm going to unmute you. Okay, go ahead.
It was a little faster in the group.
That's fine.
My first reaction is that this won't cover everybody. And it costs an arm and a leg in administration to keep all these things separately. It won't make it possible to control costs. Because you got to get a handle on prices in order to bring the costs down. So don't sound very positive, and that's correct.
Okay, so it sounds like Dr. Weinberg, this one does not get at what you were hoping to get at with universal healthcare for the reasons
Correct.
you named. Okay, Dr. Tritko. Okay.
Yeah, I'm assuming the financing is not changing, and if that's the case, on this model, you would have to somehow ensure that people participate. People can't just enter into the system when they need their surgery. So there have to be some enticement or requirement that everybody participates. Second of all, you'd have to find a way to make sure that the providers participate. So we'd have to have some requirement that everybody in the state participates, and the plan is statewide, because we want to get away from limited network plans and surprise bills. And third of all, you'd have to, part of that participation, and I know you're going to set the rates somehow, but the rates, they can't be too low, but they have to be to the point to where providers don't have an incentive to treat these patients and not Medicare patients or the like. So like Sarah, I see a few problems with this. This is going to be the simplest path forward. It's the most feasible, but we have to ensure that everybody participates on the resident side and the provider side, and that rates are somehow set to where it doesn't discriminate people on government programs, and such that the network is statewide.
Okay, Chris, I'm going to ask you to reflect on what Dr. Tritko just said. Are the things that they just mentioned things that we should write into any kind of policies or considerations in our final report, or are those also things that might factor into your actuarial analyses?
I think those are definitely valid concerns, and they are things that we would attempt to incorporate in our actuarial analyses. The enticing individuals that you mentioned, Dr. Tritko, that is a challenge because programs like this, they need a certain weight of membership in order to be successful. You know, once you can entice a large population, then you can start having more insurable risks that allow costs to be lower for everyone across the board. And that can be a struggle with something like this, is developing the incentives to get individuals in, especially because I believe this program would likely have an open enrollment period where there would be a period in the year, during the course of the year, where individuals could sign up, and maybe outside of that, if there were life-altering events like a marriage or employment change, something like that, they could then be able to enroll as well. But because of that, it can be difficult to get individuals in because you're asking for a commitment for a year for an unknown future need that they might have. I think the focus of this model could be more on a targeted population. If there is a specific need that the state feels should be met prior to transitioning to a more universal model, that could be a reasonable approach to this, to try and hit the most important need of the time right now, because there are more structures in place that could allow this program to get up and running faster than some of the other models. So that's kind of my view of it, is that it could hit a specific need while transitioning towards a more universal model.
Thanks, Chris. Jane? Uh-oh, we're having trouble on, hold on, I'm gonna unmute you just a second. There we go, you should be good now.
Okay, doke. So a couple of things to think about. Number one, I think my reaction to this model is political feasibility, probably fairly good, but also thinking about it as a transitional model, such that if whatever comes out, Cascade Care, whatever you want to call it, is appealing, and if we think about partnering with an individual mandate, potentially the pool of people that you could be bringing in initially are upwards of 700,000 people. And if you have, I agree with Dr. Tricott related regarding provider participation as well, maybe along the lines of Colorado's proposal for a public option. And then if indeed this is good, if you build it, they will come. And employers are going to be making decisions about whether they offer coverage or whether they enroll their employees in a program like this. So I think you can think about it from a transitional perspective as well as it's just this perspective.
Thank you, Jane. That actually segues to a specific question I was going to ask you about transition. But before I dive into that, I just want to see if there's any other initial reactions from some of our other work group members to this model. Any other initial reactions? Senator Randall.
Thanks, Jamie. I want to echo some of the other comments that have been said. Well, I completely agree that this is probably the most politically feasible policy, and certainly before we entered the current health crisis that we're in. I do think we're not doing as much to take most of the costs out of the system, right? We're controlling for some people's costs, but the healthcare system has just been bloating and bloating and bloating. And how can we save money overall, I think is something that we should be thinking about really, really deeply. You know, not just looking at the cost outlay for the state, but thinking about the whole universe of costs in the healthcare system. And I know that can be kind of tricky to model for, but I'm really hoping that we can think about bigger systemic change, especially in light of the huge number of folks that are now seeing the challenges in our current healthcare system as folks lose their employer-sponsored health coverage and sometimes grapple for the first time with what it means to be uninsured. I think we have an opportunity here to be maybe even bolder than we would have been in February.
So I'm hearing general, some common themes here that while some may be able to look at this model as something that could be transitional, there's still, because of the big systemic changes that we want or need, a strong interest in moving toward a more universal healthcare model, like one of the other two we're going to be discussing. Ronnie, you have your hand up.
For me, one of the big statements in here really creates my biggest question, where we said affordable employee-sponsored coverage, or affordable coverage through other sources, through exchange, through other public options. And I think it's going to be really hard to determine that, yet this is what can make a difference for individuals. The person who's working with and has an employee coverage for $8,000 deductible is going to miss out on mammograms or other high-risk tests that are life and death changes. So I really think that if we do define an option like this, we've really got to address that affordability issue and look at health equity, really look at people with different risks and specify that.
So it sounds like in both how we might construct the actuarial models, but also how some of the policy considerations that we articulate in that final report, we have to say that if this is even a transitional model, that the affordability is key and has to be addressed, right? Okay, I'm going to move us on here, and actually, Jane segued us nicely this question. This is going to be my last question for you, but I think it's worth asking now, which is recognizing that the Fill the Gaps model by its nature does not change the overall structure of the state's healthcare system and impacts only a segment of the state population. From your perspective, is this an incremental? Is this a possible first incremental step to one of the other models we're discussing today, one of the other universal healthcare models today, or is this a long-term strategy? I've heard a few of you already say that at best this is an incremental step. Does anyone have any different feelings about it that you want to share? I think, Dr. Weinberg, I'm going to unmute you.
Yeah.
There we go.
I see this more as an effort to make the whole business of reforming the healthcare system go away. From people who really don't want to change anything. And that's the people who are making gobs of money right now. And it's pretty obscene what we're seeing right now when we have hospitals with billion-dollar venture capital investments to deal with their nonprofit excesses, as well as paying enormous sums to their top executives. There are people who really want to keep the system the way it is, and this way of saying, oh, well, let's throw this little public option. And my bet out there is if the Cascade Care thing that they're working on to try to find subsidies for this plan, if that covers 2,000 more people, I will be impressed.
So Dr. Weinberg, it sounds like your concern is that if we used this model even as a transitional, it could be just a Band-Aid and we will ultimately get to a solution.
Right, I would consider it as this group failing to deal with the charge.
Okay, I'm going to ask, are there any other work group members who have some feedback on that transition before we move on? Anyone has some spoken? Yes, Mohammed. Let me unmute you here.
Oh,
there you go.
I think the affordability is really key here. For example, I work for an organization that provides health insurance, but that would be about 10% or 15% of my income, which still is not very affordable for me. And if this is something that's going to be that difficult, I don't think it's a better option than what's out there now.
Okay, so it sounds like you're echoing what Ronnie was saying, that if affordability is not addressed, it's not solving any problems from your perspective.
Yes.
Okay, thank you. Lynette? Oh, let me unmute you. Oh, there you go.
Yeah. Now I'm muted. Thank you. I agree with Sherry, and that is that this might be a Band-Aid. If that's true, fine, but I don't want to give in to just this program. I don't think it's going to do what this group is wanting to do. So if it were written in as a step along with, option B or A, yeah, I could perhaps see that, but only in transition and guaranteed.
Okay, so we have to have some clear direction that this is purely a transitional step. And some of you are really articulating that there's a risk that we could land here and not move anywhere beyond this. Okay, I'm gonna move it. Yeah, Liz.
Am I allowed to chime in?
You are. Yeah, you're.
Okay. Well, I'll chime in, and Jane can chime in if she wants to. But I mean, there is precedent for doing exactly what Lynette just described, where you take increment legislation outlines a pathway with all these pieces. We did that with covering all children in the state. It happened over a few years, but it happened.
Okay, I'm going to move us on because we only have, I think we're down to 15 minutes together, and we've got a number of other questions I want to get us through. I have a question for you about, I know you were asked in this survey if the model should be open to all Washington residents regardless of immigration status. In particular, that's an interesting question for this model because currently, as I understand it, Liz, please correct me if I get any of this wrong, that ACA only allows US citizens and documented immigrants to purchase plans on the health benefit exchange, whether or not premium tax subsidies are involved, so whether or not they're using entirely their own funds. So if a Cascade Care-like program were implemented, if this approach were implemented, there'd have to be some additional administrative solution to allow undocumented Washington residents to purchase. And that's not a non-starter, it's just a point. And they, of course, would not be able to get federal tax credits. So what are your thoughts about whether this model, when we do the actuarial analysis, should include undocumented immigrants, and why or why not? Any feedback here? Dr. Tricko.
Since I don't know how many of these people are and what it would cost, and I'd like to see some movement going forward, I just think we ought to do it with and without them. And because if it's a huge fiscal impact, then I say no, but if it's a small fiscal impact, I'd say yes.
So Chris, correct me if I'm wrong, but I understand from Shane that the model can be designed so that you can look at and compare including undocumented immigrants and not including them. Is that accurate?
Yes, yeah, we can do that. We have some data sources we can use to estimate the size of the population, and then the costs, as was mentioned, they would be more costly on a per person basis to the state because of the lack of federal funding. But yeah, that is a toggleable option we can build in the models.
So to Dr. Dritko's point, we need more information to answer the question about how we might proceed. Jason.
Yeah, I would echo the fact that we'd want to look at the affordability of the undocumented population, to scope it, to have a better understanding of what we're looking at. And I'd also like to add, I don't know how this really fits in with all the questions about the different models, but as a financing structure for as a service delivery for the state, I would be interested in what kind of effect that this type of model has on other financing within the state, particularly like uncompensated care and DISH. How would this model affect that? And I think it's important to have the non-citizen population or undocumented population really accounted for, because if you don't include them, that group does influence other parts of our financing structure. So I
Got
just
it.
wanted to echo, I would want to include as an option what this would look like. And I appreciate that you can do with and without, but those options better to have than not.
Okay.
Yes. And I do envision us looking at the offset cost, because you're right, you're not looking at the full picture if you're not factoring in the reduction in uncompensated care along with the expense of coverage for undocumented individuals. So I totally agree that that's an important thing to build into the model.
Okay, we have 10 minutes left together and 2 more questions to get through, but I see we have Ronnie followed by Senator Randall. So Ronnie?
My point or thoughts are that how can we afford not to include immigrants? We've certainly learned that lesson from COVID, that an infectious disease impacts us all. But it's important to look at even basic primary care, treating minor problems that could prevent renal failure. It doesn't take many end-stage renal disease patients to throw our entire budget out to override or kill our entire budget. So I don't see how we can not include them. I think
Sounds
we're
like
getting costs by doing that.
Sounds like you're echoing Jason's point that we really need to see not just the differences in costs for implementing this model, but also the impacts of including or not including them on other areas of finance. Senator Randall, looks like you lowered your hand. Do you have a comment here?
So I did lower my hand because Jason, brought up exactly my concern. How do we look at the costs for other programs? But what Ronnie said made me think, in my caucus, we've started thinking about how we do a racial equity analysis of many of the bills we're getting ready to introduce. And I wonder if we can include that in any and all of these models. Like what is the impact on communities of color in this model? We know that our health outcomes are so disparate on, Latinx populations and Black populations. What does it look like for moving towards health equity if we institute this model versus another?
So, I'm sorry, go ahead, Liz, please.
I was just going to respond that we have talked about that being something that we would want to look at. Betsy, do you want to pipe up for a minute here about our conversations here?
Go ahead, Liz. You can do it.
So Senator Randall, it's a really important point, and given the task of this work group that we've given a certain amount of resources for this, we do think that a clear recommendation from this work group around a next step would be to look at the models under a racial equity lens and to do an evaluation and analysis of it. We don't know if we can do it within the purview of this work group and the time and resources allocated here, but we think that it's a really important recommendation from this group.
Well said. I'm just going to pause for a moment because Mary Beth Brown, who's standing in for Secretary Weisman, lets me know that she's having some connectivity issues. So she's got to turn her video camera off. And she shared by chat that she echoes the concerns that this transitional approach might preclude moving ahead with reducing the fragmentation in the current system. Okay. So I wanted to make sure that you heard from her as well. Any other comments on including, sounds like we're all generally in agreement that we would like to have the data to be able to compare. And so we are asking our actuaries to add that. They always laugh when I say the button that you can toggle on to say that we want to include undocumented residents in our model, but I'm sure it's not as simple as a button. So let's move on then. Here's a question about coverage. Should this model include or allow those with access to employer-sponsored insurance who are not able to afford their contributions, their cost sharing, to participate in this Fill the Gaps model? And why or why not? Any thoughts here?
So this is Jane. Just to clarify, is the question that you're asking whether, because under the Affordable Care Act, right, if you have minimum essential coverage elsewhere, you're not eligible to purchase coverage through the exchange. So essentially you're asking whether under this model, there shouldn't be a minimum essential coverage provision so that if I have coverage through my employer, but I think it costs too much, I don't have to take that up and I can come into this program.
Right. Exactly. Well put.
Or
Yes,
like
that's a good-
the family glitch issue.
Right. Well, I mean, if this program is going to set a standard for affordability for income or percentage of income, if somebody could not, and again here, Liz, it's not only the family glitch, it's the 9.8% standard.
Yeah.
So if this program has a standard of, let's say, 6% or 5% or whatever, and somebody can't get coverage for that share of their income in employer-sponsored coverage, then if what we're talking about is and concerned about is affordability, it would make sense to have this as an option for those folks.
Okay, so to clarify, just for those of us who are maybe less schooled, when we're talking about the 9.8 standard, standard, no, that's okay. We just mean a proportion of our income. And so if this program is setting, if our intent is for this program to make this affordable, even if someone has access to coverage, but it exceeds that standard, it would make sense to include them in here. Dr. Weinberg, I see you raising your hand. I'll unmute you. Just bear with me. Seems like I have to click this a few times to make it happen. There we go.
Two things. First of all, the current affordability standards only talk about being able to afford the premium. So of course the insurance companies respond by keeping the premium down and the cost sharing way high. So yeah, you can afford the premium, but then if you have an $8,000 deductible, you can't afford to use it anyway. And my general reaction to this, this issue is changing deck chairs on the Titanic.
Okay, so I'm hearing two things. One is affordability is all of the cost sharing from your perspective, not just the premiums, but also out of pocket and deductibles. And I like your analogy with the Titanic. Any other feedback on allowing folks who have access to to employer coverage that's not necessarily affordable? Mohammed.
Yeah, I think by allowing people to switch over if this is more affordable to them would also help with getting enough number of people on these plans to move forward, I think. So it's a little incentive for people who's out there like having insurance but not able to use them because of affordability. So it might be a good thing to consider.
So it sounds like, to Jane's earlier point, if you build it, they will come, that one of the keys would be to make it possible for people to come here to get more affordable coverage from your perspective. Okay. Yes, Senator Randall.
I think what this might also solve for is, knock on wood, we enter another crazy pandemic unemployment surge like this one. You know, we're able to prevent those gaps in coverage. While folks do have, you know, the open enrollment period when they have a triggering event, a lot of folks don't know that, right? And you have to find the information to then get, you know, access to AppleCare or to buy a plan on the exchange. And that is an extra step that could, you know, keep people from getting the care that they need when they need it. So if we're able to provide an opportunity for folks to get affordable, dependable coverage, that then they don't end up with a gap when they do become unemployed.
So it sounds like you're saying this might be a partially mitigating strategy in case we face a similar catastrophe to what we're dealing with right now. Okay, we have 2 minutes left together. I have one last sort of bigger question for you, which is and I know some of you feel like this model maybe is not one you would like to see at all, but which, if any, elements of this model, any additional elements that we haven't discussed of this model, should be modified? Do you have any final thoughts that we didn't throw out there about what else might be modified? Dr. Tritko.
Well, I just have to point out that we already have a really good affordable model in the state with 1 million enrollees, which is the state employee health plan. Simply adding these people to that would be one of the easier models that is very feasible. And the advantage would be is that it's a very affordable plan compared to any of the exchange plans.
Okay, so then rather than doing this fill the gaps model, we could consider expanding the public employees coverage to other folks. Any other thoughts here? Yes, Dr. Weinberg. Let me unmute you. Hold on. Looks like I have to click 3 times to make it happen.
No, I have to click it. It comes
Oh.
up to okay your click.
Okay.
Dr. Tritko's case, I believe that the state plan has issues with the federal rules regarding tax deductions and the like for the state for its employees. And if they expand it to include the hoi polloi out there, then they lose, the state loses this federal benefit. And I certainly can't tell details, but it's a substantial amount of money that the state gets as a result of insuring its employees.
Oh, okay.
That it would lose if it opened it to the general public.
Okay, so it sounds like there might be a barrier that would be insurmountable to doing.
And papers have been written about that from Connecticut. I'm sure Jane can tell you. These are people that are not employees, so would not have any tax consequences whatsoever. So it can be done, but you'd have to, I can give you the articles that have been written. I know it was written for Connecticut, and when they were looking at that.
So I'm going to have to pause here because Liz and Chris and I are about to be beamed out of this room. So I just want to let you know, all of you can just, we'll miss you. All of you can just stay here. You don't have to do anything. Definitely don't click any buttons because I don't want to lose you. But your next round of facilitators, your next round of discussion, some of you be very happy to be discussing one of the universal healthcare models instead of this one. So we'll see you in the main room shortly, but it was very nice to spend 30 minutes with you. I'm going to now wait here awkwardly until I get switched out. You can talk amongst yourselves.
I think the issue that Rod started us with of provider participation is critical. And I know our Office of the Insurance Commissioner is dealing with issues around that, but I believe that's something we'll have to be even more specific in our plan. And it certainly would affect the actuarial analysis. How do you include these providers? Do you have to pay X% more than Medicare or what? I think that Rod brought up a really critical issue.
Lynette, this is from Sherry Weinberg. You should have gotten an email from Glenn Anderson just within the last day.
Yes, Sherry, I did. And it was a compliment that you gave me to be with you on an interview. And I will certainly join. I'm going to, after I'm done here, I'll email him back.
Sounds great. Copy me on the email, okay?
Okay, will do.
Thank you.
Hi, you guys may have noticed that some people have disappeared and come back. I'm Janine Smith from HMA, and I'm joined by Shane Mofford from Optimus. And we are the discussants, facilitators to discuss Model A, the universal coverage state administered model that many of you probably already reviewed during the pre-work. And we have a series of questions. Some of them are similar to when you get to, I think you just did fill in the gaps, is that correct? Is that the one you were just doing? And some of these questions apply probably to both of the universal ones, but we kind of split them off to be more specific to this one as much as we could. And we want to try and get as much feedback as we can to help Shane and Jared at Optimus to start to fluff out and refine these potential straw models. So with that, I think so is there questions at all about the model itself? This is the one where everyone in Washington state would participate. The state defines the benefit package. The state sets all the rules around the delivery system, and there are no healthcare plans or carriers between the state and the providers. And then there was the variant of whether that this universal model included all of the everyone in Washington, regardless of if they're on Medicare or Medicaid, or whether we folded that in. So were there questions about the model overall before I go into some questions specifically for you? No? Okay. So one of the questions, and we had a lively discussion in the last group about whether there would be a need for a mandate for this. So if you're saying that all residents are eligible, would you need to mandate it, like say the ACA had a mandate to have coverage, and there was an enforcement process for that for a while? Or is it more like a Medicare, you are now all eligible and you sign up for it? And so any thoughts about that, whether you will need a mandate or not need a mandate affiliated with this one? Because it does have an impact, and Shane can go into the details, but is everyone in, or can people opt out? Sarah, do you want to, yeah, I think you're still muted.
First of all, I wrote a bill that would have enacted the Washington Health Security Trust, which would be essentially this model. I wrote it, it was written in my basement with a bunch of friends 20 years ago. So I know quite a bit about this. And what we said at the time is that the first time somebody wanders into a healthcare provider, they would be signed up, and they would also be liable for any past premiums or anything if they hadn't already paid according to the tax or premiums or whatever they would require. But basically, your initial contact, that would sweep everybody in who hadn't already just done it.
Mm-hmm. Yeah. Other thoughts about whether this model will need a mandate, or you want it to have a mandate, or you sweep everyone in like the trust, or do you something like the trust model?
Janine, I saw Dr. Trickco with his hand up, and Ronnie.
Okay. So,
well, to take a step back, I'm assuming we're talking about option A, correct?
Correct.
So, you know, there you're changing the financing, I'm assuming, and there's going to have to be a transition period. So, I mean, say you wanted to do, you couldn't do this by January 1, even if you wanted to, for a number of reasons, because you'd have to get all sorts of different waivers, including federal waivers. The state doesn't have any contracts with any of the providers. So they have to negotiate a contract with all the providers. That would take years. And finally, the state doesn't have the mechanisms or the administrative ability to process claims. I mean, they tried that back in the 90s, both with Uniform and with Medicaid, and it was kind of a disaster. They decided, kind of like what Medicare does, is that it's just better to use a third-party administrator. It seems to me they're not planning on doing that, because that would fall closer to B than A. So I don't understand the mandate, because there's going to have to be some sort of transition period, and then everybody will be in it.
Okay. And this question probably does apply to both A and B, but in terms of mandate. But Ronnie, your hand was up.
And so I think the issue is, or the wording should not be mandate, but should be simply that we do include everyone in the state, that it should be an automatic approval. If we are all paying for it, we should all be eligible for it. So I think the critical issue is to include everyone, and that I don't think the right word is mandate. I think it is, the right word is universal, that we are included in, you know, the initial approval for this group.
And so somewhat similar to Medicare, right? You are eligible, but as you reach a certain age, at least, and you sort of get automatically enrolled in at least some of it. You don't have to buy the portions of it separately. Pardon me? Say that again.
The age for getting it enrolled would be birth, when as soon as you.
Right. Instead of 65. Right. Okay. So what an issue then also comes up, would there be ability to either purchase a supplemental or substitute coverage? So if someone didn't want to be part of the universal model, would, they just wanted to buy on, would there still be a market? Thoughts of that? Sarah has her physical hand up.
Yeah, well, of course, we thought about this when we were writing the WISP 20 years ago. And you can see what's happened in countries like England and to some extent some other countries with universal health coverage, that if you start allowing those with means to buy outside the group and pay more to their providers, you immediately develop a two-tiered system, one for the poor and one for the wealthy. And you want to avoid that. Canada tries to do that by outlawing any insurance that covers that covers the package, the benefits. And insurance can only be sold for items outside that basic benefit package. And that is essential to avoid developing a two-tiered system. And while I've got 1 second more, you also have to worry about underfunding, because that's the other thing that drives a two-tiered system. If you underfund the system for everybody, the rich will opt out.
Janine, I'm sorry to jump in, but I think because you're not on mute while others are talking, there's a lot of feedback. So you may want to mute yourself. Well, yeah. And then one other thing that we may want to do is just get some general observations about this option one. I know I'm going off the playbook, but that was very helpful in the last session, just to get kind of people's general temperature about the option. And I think Dr. Tricko was going there.
Does that mean I can talk? Hopefully Sarah understands that this is not 20 years ago and things have changed dramatically, and people in Canada can always come to the US to get coverage. I see this in Arizona all the time. In fact, they prefer coverage in Arizona, and it's not like that we can go up to Canada to get care. So I think what we want to give people is options and choice, not to limit that. And it just makes no sense to take away their options, particularly when we're in a country with 50 states. I can go to any other state and buy insurance, and I should be able to.
And Ronnie had your hand up? No? So what I'm hearing is not necessarily need a mandate, that it's more that you are universally engaged, of ability to have this, that there might be some potential buy insurance of beyond what's being offered potentially. And what about in terms of exclusion or inclusion of Medicaid, Medicare? What are your thoughts about the variant 1.5?
There are 8 groups that are federally protected: ERISA, Medicare, Medicaid, Taft-Hartley labor funds, the VA, military, and the Indian Health Service. Let's see, that's 7. I've left somebody out. Oh, I didn't cover ERISA. So those have to be dealt with in some way or another in order to set up any state plan.
Are there thoughts at all, though, in terms of, as you think about the benefits, so the sort of general feedback we have gotten in the discussion groups and in the survey were going with the Washington State Essential Health Benefit Package. Now we know that Medicaid has some enhanced benefits on top of that. Adult vision and dental are often raised as benefits that are not usually included. Thoughts about alternative chiropractic, acupuncture, those types of benefits aren't usually included, and then there's long-term care. So does this group have some thoughts about how you would manage benefits beyond going with the essential health benefit? And again, I still see hands raised with Dr. Trico and Jason. I think you haven't talked yet. Do you want to weigh in?
We've got Jason, Lynette, and Jane. Janine, I see.
Yeah, I think I think you touched on a really good point. I think you'd be really hard pressed to align all of the benefit packages, laws, and mandates of all of the programs that Dr. Weinberg mentioned. Those are some very disparate programs that cover different things in their own way, in their own systems. Specifically, the VA and the military, they have their own hospital groups that provide these things, and it would be difficult to align how they do, what they do, and where they do it at. It'd be extremely difficult. So I do support the essential benefit package that the state would put together. And then I think, I don't know if this would work or not, and I think others may have suggested it previously, but I mean, some type of supplemental program for those other groups would potentially be helpful to, potentially like a buy-in program that I'm covered by the 8 other plans, and then you could add like some type of buy-in on top of that to get to the essential benefits that we have or are going to set up. And I think choice is an important part too, but those are my comments.
Yeah.
Go with Lynette.
Okay, great. Yeah, actually, Jason, I think those are really good ideas. On our printout, it does show this. I think your question is the 1.5. If we pull out that group that's federally funded healthcare, it might be easier to transition again to the entire model. But for a while, I think people would go with it easier. And Jason, you're spot on. It's kind of the American way, unfortunately, or maybe not. Choice. Yeah, thank you.
All right, Jane.
So Jean, just to respond to your question about alternative providers, Washington State, this is almost like a technical response. Washington State has a statute called Every Category of Provider that applies to private health insurance. So if an insurer covers outpatient services for back pain, then they need to have in their network all of the providers for whom treating back pain is within their scope of practice. So I would say one assumes in doing the modeling that every category of provider stays in place, given the fact that that statute's been law since, I think, 1993.
This is Shane. I do have a question about that, because obviously implementing universal health care would require significant statute changes. Is it safe to assume that we would not touch other healthcare statutes? Like, should it be in the purview to evaluate that?
So here's what I would say, Shane. That provision was part of the big Health Services Act, I think, that we did in 1993. And it was an alternative to an any willing provider statute. And it was basically put into law to make sure there's an adequate type and diversity of providers that are offered in health insurance, but to still give insurers. And again, in number one, we don't have insurers, but to still have the ability to have certain quality standards, et cetera, for the providers that are participating in the program. So that's just the historical context behind it.
Gotcha, thanks.
Okay. Looks like Dr. Trico's hand is up, and then Lynette again.
Yeah, the any category provider was designed by the physicians because they were scared to death that health plans would exclude them. You got to remember, this was in the middle of the managed care crisis. And the thought is that every physician could be involved. What happened with that bill was it was written in a way to where all of the other providers immediately asked for scope increases, and suddenly they got into it. So I think, Shane, that would be something that we ought to look at again, because the more providers you add to any panel, clearly the higher the costs are going to be. And what we're trying to do is to reduce variability and have the highest standard of care.
And Lynette, do you want to add? No? Okay. So, Sarah?
I can't resist. And during the period of time where they were working to implement the Health Services Act of 1993, they had hearings around the state on the issue of what should be included in the benefit package. I went to a couple of those hearings because I was a real close friend of Randy Revelle, who was the executive director of the commission at that time. I listened to people like iridologists, reflexologists, homeopaths, all begging to be included. I think we didn't hear from the folks using coffee enemas over in Bellevue somewhere, but darn near. So that's how any willing provider was brought in, thanks to our then insurance commissioner, Deborah Sen. Just a historical.
The other benefit area is long-term care, and we know there's legislation that was passed, and a program is being in the process of being implemented. What do you think about how long-term care would relate as a benefit inside this universal package of? Lynette, your hand's up. Did you want to say something?
Actually, I will, but nobody's put my hand back down. And I think you folks are in the controls on that. It's hard to think long-term care not being in this. It'd be great in the actuarials that we, once again, like immigrants, how much will it cost with them in or not? We certainly have been awakened about our long-term care facilities with the COVID-19, that something has got to happen. Now, state of Washington, I think, does pretty well with regulation, but it's healthcare.
Others have thoughts around long-term care? Dr. Trico?
Well, I remember back around 92, 93 when or actually it's a little bit before that, when Medicare tried to do it, everybody was for it until they realized how much it would cost. And I remember the scene of them trying to roll Dan Rostenkowski's car over in Illinois. So I think we ought to at least model it with and without, but I think the price tag is going to reduce people's interest in it.
Sarah?
Again, going back to writing the Washington Health Security Trust 20 years ago, we considered that long-term care was very expensive. And so we wrote into the bill that the state would study the cost of including long-term care at some time in the future. But we didn't want to sink the universal health care coverage idea by adding long-term care at the beginning.
Any thoughts others have about that? Is this something that you would consider for later or more immediately, or? Emily and Dennis, we haven't heard much from you two. Or thoughts about this? We have about 5 minutes left about this particular model, some benefits.
And Ronnie's got his hand raised too, Janine, sorry.
Okay, go ahead.
Where the others wanted to go first, Emily or?
Sure, I would just say that I agree with the idea, if possible, of modeling cost with, cost without long-term care. We made some strides with the long-term care trust, but we know that that's not anywhere near to covering everyone's needs, and knowing how expensive it would be and how expensive it would be could help us make a better informed decision.
Ronnie?
I think it should include long-term care because we are paying for it already through Medicaid, through our Department of Corrections, which has a significant population that is ending up as long-term care patients. And we've really gotten a great head start with our current legislation around that. Including it within healthcare benefits would be the most logical next step. And I think we can be one of the leaders in the country in making that happen.
And Dennis, do you want to go ahead and add in some thoughts, since we're about short on, going to disappear here in a minute? You're muted.
Well, now I'm not. Okay, well, back when the 1993 Act was considered, we were looking at wanting to have long-term care, but put it out into the future as kind of a commitment that we will look at that, mainly because we wouldn't have been able to get the votes, the support for it because of the cost. The same thing's true with these other programs like the VA and the labor unions. We had a big battle with them until we finally excluded them from requiring them to join in with us. And it's a battle I don't think we need to fight. If we designed a program that was a good program, they could voluntarily come in. But I don't see many of these military or Boeing type workers that are going to want to join in, and they will fight us tooth and nail. As far as the benefits go, as far as like chiropractor and witchcraft and some of the others, that was one of the difficult battles too, because we had to discuss each one and come up with a determination where they would be considered if in fact they did provide a benefit to the patients. If they didn't, you had to give authority to the insurance companies at that time to be able to not cover them, and that makes sense, but you need to give them an access. If acupuncture or chiropractor works, then you need to cover them. So that's my thoughts.
So I think we're going to all disappear here in a minute. If Jane, if you want to, you might all be able to hear each other, but go ahead.
Right, just one thing I wanted to note really quickly, in the Balanced Billing Protection Act that the state just passed, there was an option for self-funded group health plans to opt in, and over 225 self-funded employers said, I want to provide these protections to my employees, and they have opted in. So I think it does go to the issue of, if the state builds something that's good and gives self-funded employers the opportunity to come in, they may indeed take it.
All right, I think we are disappearing into a break for about 5 or 10 minutes at this juncture. So if we all evaporate, that's what's happening. And they'll be moving us on into a next room.
Hey, thanks everyone for your feedback.
Yes, thank you.
Well, Jane, this is deja vu all over again, eh?
I would like to point out to Rod Tritko's comment about Canadians choosing to get their health care in Arizona. Canadians are required to buy private insurance when they go to the United States for an extended period of time to cover anything that they have while they're there. I don't know how many of them choose to get sick while they're in Arizona or choose to get elective care while they're in Arizona, but they are required to buy insurance to indemnify the Canadian system when they travel to the United States for extensive periods of time.
All right, we will see you all in 2:45, so 5 more minutes of break. Thank you. Great. Okay. Hello, everyone.
Not really everyone.
Hello, everyone that I can see. Okay. I don't know if I am still looking for Jared. So maybe he's not yet in the room.
Nora, do you want me to let Liz know?
Yeah, I was going to see if I could just send a note to Jared.
I'll have him send him over.
All right. Yes. A little bit of Red Rover.
So Rod, are you living up here in Washington or are you down in Arizona?
No, I'm back in Washington. Too much coronavirus down there.
Right. You got out of there in time.
Plus, I didn't want to go to the Trump rally.
We're not going to have one in Spokane.
A Trump rally? Let's hope not.
How about Wenatchee?
How about Yakima?
Okay. So task one, as you may have been told in the other rooms, is for me to try to keep the discussion on track. So I'm going to bring it back to this coverage model, and just remind you that the more specific you can be in your comments, the better, the more useful for well, both for the actuarial and financial modeling, as well as for our overall program development. So let me first read you the little description again, since you've been talking about other models. So this is universal coverage delegated administration. And under this model, all permanent Washington residents will receive health insurance coverage through a single statewide health plan. The state will delegate most financial risk and payer-related functionality and delivery system management to private insurance companies. There's a single source of coverage that is administered by multiple organizations. Providers are private, as they are now. This model can either be seen as an end state on its own, or as a transitional model that as a state migrates to a fully state-run model. And just noting that this model partially protects the existing infrastructure in terms of jobs, technology, experience with managing benefits and payments, but also preserves market fragmentation that exists now. So we have 3 areas of questions, and I'm hoping that we can get your input across all of them. So the first one is around cost sharing. And that is a question that really applies both to the this model and the universal aid. The question of whether individuals who participate would be paying monthly premiums, any kind of cost sharing, deductibles, co-payments, etc. So we're going to talk about that. The second one is about the level of autonomy or standardization. How much should the state be defining for the insurers, and how much should insurers be allowed to differentiate themselves?
And then the third is around transition, whether this is an end state or a transition to another, to basically option A, more state entirely organized. So I have been terrible about making sure that we spend enough time on each one, but Jared is going to totally, virtually remind me, wave his hands, jump up and down, whatever he has to do to get me to make sure I include it.
Okay.
So, and then the way we've been doing it is I'm trying to write down what we all are, what folks are saying. And so Jared is tracking who's raising their hand. If you can use the little hand raising function or even literally raise your hand, then Jared can see you and kind of put you in a queue for who will talk. So let's talk about whether the model should include some form of cost sharing beneficiaries and why or why not. And that could be any of these, whether everybody pays premiums, whether it's point of service, et cetera, whether it's a unified, everybody pays the same thing, or whether it's based on income, free range within that topic.
Sarah, you're on mute, just so you know.
Yeah. Well, first of all, any direct cost sharing at the point of service serves as a cost barrier to people getting the health care they need when they need it. So I think that allowing cost sharing would be a mistake. And especially if cost sharing was different with certain plans than with other plans, we would quickly get a multi-tiered system where the rich would pick ones with more, that they could afford more cost sharing, and the poor or the sick would all be in the ones with less cost sharing, and you would destroy your universal system. Nations that have built their universal systems with intermediary insurance companies, in reality, those insurance companies are basically claims processors and fund distributors. They do not make decisions about medical care and all of that. And essentially, everybody's in everything. If you look at the German model.
Thanks, Sarah. Rod?
I'm looking at somebody typing. I was wondering about option B of whether this was an all-payer or single sponsor. I'd start off by saying the state, when it tried to manage claims and process claims, sucked at it. It got out of the business. I've never heard anybody say that in a Medicare for all, that we ought to get rid of the Medicare contractors, because they actually do a really good job. As for there being the eventual development of tiers in an all-payer system where everybody is paid the same, everybody has to participate, and there's an individual mandate, that's not going to be the case at all. So when we look at the various options, if option B is to leave a lot of the financing mechanisms alone, which would be more of a 2.5, and if we have an individual mandate and we have a provider mandate, and we're really good at regulating the market, the providers, kind of like trying to develop in a lot of European countries, suddenly we see an option that we can get to in a year or two that is going to provide universal coverage and not need a whole lot of federal participation.
Thank you, Rod. Others have comments?
And just by the way, I am typing up notes because if we were in person, we would have boards to write everything down just so people can see I'm including all of the comments.
All right, Ronnie, why don't you go ahead? You're on mute.
Now I'm off mute.
All right.
And I believe that it is important to look at sharing and co-payments if we have any as ability to pay as income ability to pay. And part of that is, or the main reason for that is the profit motive in our system has led to enormous costs, which seem to penalize a person if they get a certain disease. If you get multiple sclerosis that requires treatment with a specialty drug, even if you're rich, it becomes a cost barrier, and it seems like a penalty. So I think that if we're going to look at cost sharing, we really need to base it on a progressive income, or looking at more progressively at a way to base it on income. Then and I think all of the systems that we have developed have assistance if you are at lower incomes, certain percentages of the poverty level. But if you have a disease that is, that our current system uses to raise funds for their own business, that it becomes a problem. And I guess I have a second completely different point. Should I talk about?
Sure, go ahead.
Yeah. And I've forgotten what it was. No, it's not about, co-payments as much as it's about the insurance industry itself, that there certainly, as Rod said, there are useful benefits managers that come in and help with Medicaid nationally by providing rational care or evidence-based medicine and providing guidelines like that. But there are just way too many benefit managers that are not transparent. As a pharmacist, I know that when someone shows me an insurance card from Blue Cross or something, that a denial that will come across on a particular drug is not from Blue Cross. If, when I call to ask a question about that, it's a benefit manager completely separate or on top of what the insurance company is doing. And so when we look at the advantages of the state, or like with Medicare, with the national government using or providing the benefit, being the benefit manager itself, that we really are adding costs to government, but it's a logical role for government that can save a significant percentage of insurance costs and can make a real difference. So this option seems to be ignoring some of those profit motives in our system.
Okay, thank you, Ronnie. Dennis, you had a comment? Looks like you're on mute as well. There you go.
Yes, I do. I think we should minimize the burden to the patient as much as possible, and that decision can be made depending upon how much this is going to cost the state. But one of the things we learned in '93 was that from Group Health, they said that they had a number of people that would just come in socially to talk to the nurses and the doctors. And then they added a $5 visiting fee, and it reduced the social calls, and they made a decision to show up if in fact they needed some medical care. And so if in fact we decide that there is a need for some contribution from the patient, well, that would make sense. But if we don't, I think we've got to just watch the burden so that the patients are not going to be faced with those $10,000 copays that means they don't even have insurance. So I think that's, in '93, I think we put down a $10 fee that would be charged for each person to come in for a visit. Not very high, but still made you think twice before you just drop by to see a nurse.
Okay. Nora, were there other pieces you wanted to move to? It looks like we probably got, what, maybe 15 more minutes?
Yeah, so if there are other folks, these are some of the comments that other folks had in the other sessions, but if there are folks who want to talk about kind of, I've heard some comments about the interest in having insurers act as administrative processors and not setting the rules, having the state set the rules. If there are others who wanted to chime in on that, as well as to talk about whether people see this as a transition state or a potentially an end state.
Sarah, go ahead. You're on mute.
First of all, basically, we're just putting another layer of administration between the physicians and the patients in this model, which has to cost money. In the first model, the one where the state has total responsibility for the financing and paying for healthcare, the state would be perfectly free to contract, as Medicare does, with various private companies for their claims processing and payment abilities, which in fact with Medicare works pretty smoothly. So that they can be used that way, but putting them in the middle like this, what it does is it interferes. Under the first option, patients can choose any provider. They do not have to change providers. In the second one, they would be restricted to providers that are on the list for that insurance, the insurance company that they sign up with. And as we all know, insurance companies play musical chairs with their lists so that providers are on one day and off the next, and it can be impossible to find out who's on and who's off. So I think it's using insurance companies for their claims processing ability, obeying the rules set by the state, and they're having nothing to do with prices and negotiating and all of that with providers would be a good idea.
Thank you. Jason.
Yeah, thank you. I would be interested to know, as an option through our actuarial analysis, the benefit, some type of benefit analysis around what value add insurance companies could bring to it versus, so you could have an insurance company that is just paying the bills, being a third-party administrator, prior authorizations, doing what the state tells it to do. And then on the other hand, you could have, it has as a guide or rules that the state gives them, but also what kind of value added benefits could be added to that in interest of acquiring more market share for that insurance company. So using profit and as a tool to help Washingtonians better.
Okay. Thank you. Rod?
Well, in fact, we have 28 years of experience of managing care ever since the fee schedule went into effect in 1992. We moved away from the usual and customary health plans and Medicare and Medicaid, and everybody's been trying to figure out how can we make sure that we are only paying and paying appropriately for cost-effective care. It's an extraordinarily difficult task. If we were to just have an open fee-for-service, system in the state of Washington, and we were just going to use the carriers to process the claims and not to manage the care, prices would just go through the roof. Medicare does this very well, and it's not the Medicare carrier, at least under B, doing it. This is coming from CMS office nationally. So I think that we have to understand that health plans and carriers have a necessary role to manage care, to emphasize high value care, and last but not least, to eliminate care that actually makes people worse off, or care that is billed and is simply not what they're saying it was, a fraudulent bill. carriers have a very, very important role to play in all of this, and we have 28 years of experience doing this.
Thank you, Rod. So we're going to go to Jane, and then after Jane, we're going to go to Jason. Go ahead, Jane.
Thanks. So I guess a couple of points. In this model, and I think Rod sort of alluded to this, there are differing levels of how active a purchaser the state is going to be in terms of what standards it's going to set for any kind of contracting insurer. And Medicare Advantage is probably one of the more active in terms of the parameters being set. So I don't know how, in the context of your actuarial modeling, we can try to look at sort of how directive the state is around its role as a purchaser. And then the other question that I had was, and this almost relates to both option model 1.
Oh, it looks like.
Jane, you went through some kind of a dead.
Oh, okay.
Right, well,
can you hear me now?
Oh.
Yeah.
Yeah.
Oh, it looks like your video is
insurance company out of the picture.
Oh.
Jane, we're having problems hearing you, so maybe we'll give it a couple of minutes, and then if you're in a place where you're
can
better
you hear me?
able to hear.
Jane, why don't you try, this is Gary Swanwell at HCA, why don't you try shutting off your video and just go to audio only? It seems like you're having some connection issues.
Yeah, and in the meantime, Jason, do you want to make your comment? It looks like you're good? Okay. Jane, are you back on or?
Let's see. Can you hear me now?
We can.
No. Yes, sir. Okay, great. Okay, so just the point that I was going to make is if you take the insurance companies out of the model, there are a whole bunch of questions about how the state would contract with providers. So is it capitation or subcapitation with big, massive physician groups or physician hospital systems? And that raises some of the same issues that contracting with an insurance company does, just in terms of how much the provider group is going to manage the care that somebody gets. So I guess the question is, for the first model, if the first model is talking about pure fee-for-service, looks just like the old indemnity plans, that's one thing. But if the first model is looking at contracting directly with providers, how much do we need to take into consideration the kinds of contracting models that would be in place, the use of value-based purchasing, the use of capitation, because that makes a big difference. Thanks.
Okay, thank you, Jane. Were there others? Oh, Sarah, I saw you raise your hand.
Yes. This just reminds me of how much things have changed since 2000, when I was involved in writing the Washington Health Security Trust, and we didn't have giant hospital conglomerates that have bought up every surrounding medical practice. We didn't have venture capitalists owning dermatology and anesthesiology practices and keeping them out of network so they can bill sky-high bills and you have to pay them. That's what surprise billing is. So it's much more difficult to implement now than it would have been 20 years ago. The current for-profit running healthcare as a profit-making business is thoroughly entrenched. And I think to undo it, you have to use global budgeting with some of these very large groups and negotiate an annual budget for that group to provide the care that they normally provide. When we were originally writing it as the Health Security Trust, we considered that for hospitals, but I think now it would be needed for some of these very large groups as well. But that is kind of how you can get at this problem, giving them a budget and saying, okay, you practice within it.
Thank you. Well, we got the pre-hook telling us 2 minutes before we get this is over. So are there any other last comments? Rod?
Yeah, I'd point out that, over the last 10 years, Medicare has tried a number of different mechanisms for managing costs. Basically, none of them have worked. All of the ACO models have been medical home. All of those haven't worked that well. And what it comes down to is what Sarah says, are global budgets. Unfortunately, not on a provider level, but on a state level. Maryland is way along in developing this with a model very much like option B. And I think it's a model that we ought to be looking at.
Thank you. Looks like, are you getting the cue to leave? I got the button show up on my screen.
We're getting the hook.
Yep, we're getting the hook.
At this point, since we've done all 3 of the sessions, hopefully you've had 3 separate conversations, we're going to be coming back as a full group to talk about what the discussions were like across the groups. So hopefully you should see